So welcome to Medico Importance Simplified. So we are going to cover all the basics of history taking and examination in obstetrics and gynecology completely. This is going to be a complete series only focusing on the clinics of OBG. So now let's start with the basics of obstetrics. So the terminologies are this is going to be a rapid session. So yeah, the terminologies are going to be very important. So first, what is gravida? Gravida refers to the number of pregnancies including the present pregnancy the woman has had irrespective of the period of gestation and the pregnancy outcome. So it includes the present pregnancy also. Gravida is the number of pregnancies including the present pregnancy irrespective, this is important, irrespective of the period of gestation and pregnancy outcome. Now what is para then? Para is also refers to the number of pregnancies but that have crossed the period of viability. So generally what is the period of viability, guys? The period of viability is around 28 weeks. So the number of pregnancies that have crossed the period of viability excluding the present pregnancy. Next, what is live? L for live birth. So refers to the number of living children at present. While taking history, you need to see how many number of children the woman is having at present. And what is abortion? Abortion refers to the expulsion of products of conception. Expulsion of products of conception before the period of viability, that is 28 weeks. So abortion is expulsion of products of conception before the period of viability. So this is very very important for Viva. They will definitely ask what is gravida, what is para, what is live birth, and what is abortion. So this is the obstetric score. Obstetric score GPLA. So for example, I am giving a case scenario. So there is a woman who's coming with the period of gestation of around 30 weeks, and this is her second pregnancy, and she had one abortion. So and the first one was an abortion. Second one, she has a boy baby, and was a boy baby, and around 5 years old. And this is the third pregnancy. So what will be the score? The score will be G. So 3 pregnancies are there. Gravida is including the present pregnancy. So for all the pregnancies done, irrespective of the period of gestation. So the gravida will be 3, G3. Para will be excluding the present pregnancy and only the pregnancies that have crossed the viability, right? So number of pregnancies that have crossed the viability excluding the present pregnancy. So para will be 1, and live birth will be 1. Abortion will be 0. So this is an example. So what is viability? Viability refers to the ability of the fetus to survive outside the uterus after birth. So period of viability varies in different countries, guys. So in India, remember, it's 28 weeks. Whereas in developed countries like US or UK, the period of gestation around 24 to 26 weeks. So you need to ask for any previous history of multiple pregnancy. So previous history of multiple pregnancy parity is determined by the number of previous viable pregnancies and not by the number of fetus delivered. Hence parity remains the same if previous twins or triplets were born. And you need to ask for any previous history of vesicular mole and ectopic pregnancy is also included under abortion. So any vesicular mole or ectopic pregnancy, both of them are included under abortion. And parity is important for the history of multiple pregnancy. So So let's talk about various terminologies again used in obstetrics, like what is primigravida? The woman is pregnant for first time. What is multigravida? Already have a is a known case of previous pregnancy. Already the woman has had one pregnancy, and irrespective of the pregnancy outcome, she might have aborted or delivered. So that is so far how many pregnancies? If already there is one pregnancy, then it comes under multigravida. What is nulliparous? A woman who has never carried a previous pregnancy up to the period of viability. So if a woman has not been carried any pregnancy up till the period of viability, will come under nulliparous. And if a woman who has had one previous viable, this viable word is important. So viability is important. Nulliparous means a woman who has who has never carried a viable child. Okay, who has never carried a viable pregnancy. Whereas primiparous is woman who has had one previous viable pregnancy. Multiparous is women who has had two or more previous viable pregnancies. What do you mean by grand multipara? Grand multipara means women who have had 5 or more previous viable pregnancies. What is nulligravida? Nulligravida is women who has never been pregnant so far at all. So has never been pregnant. That is nulligravida. What do you mean by parturient? Parturient is nothing but a woman who is in labor. We call them to be as a parturient. Who is in labor. Puerperal, woman has just delivered a baby. Women who has just delivered a baby will be termed as puerperal, because something called as puerperium period. So puerperium period is delivery up till 6 weeks is puerperium period. So under the period, that women will be referred to as puerperal. Now trimesters in pregnancy: first trimester, second trimester, third trimester. First trimester is from the time of conception up till 12 completed weeks of gestation is first trimester. Second is from 13th week up till 28th completed weeks of gestation is second trimester. Third trimester is from 29th week up till delivery. So up till 12, from conception to 12 is first trimester. From 13th to 28th is second trimester. And from 29th up till delivery will be your third trimester. Now what is term, preterm or postterm pregnancy? Term pregnancy means pregnancy after 37 completed weeks of gestation. Remember 37. Whereas preterm means pregnancy after 28 weeks but before 37 weeks. That is, preterm is pregnancy after 28 weeks but before 37 weeks. So during this period is preterm. Postdated pregnancy means what? Postdated pregnancy is pregnancy continuing beyond 40 weeks up till 42 weeks. That is, beyond 40 weeks but up till 42 weeks. And what is prolonged or post-term pregnancy? This is post-dated. Post-dated is between 40 and 42 weeks. Whereas prolonged or post-term pregnancy is beyond 42 weeks. Simple. Now next, moving on. How to calculate EDD? EDD is expected date of delivery, and how to calculate period of gestation. So expected date of delivery is calculated from the first day of last menstrual cycle using a rule called as Naegeli's rule. So very, very important. What is Naegeli's rule? Naegeli's rule. So this formula must be memorized thoroughly. Expected date of delivery is nothing but the last menstrual period plus 9 months plus 7 days. Expected date of delivery is last menstrual period plus 9 months, last menstrual period plus 9 months plus 7 days. For a woman with but remember guys, this Naegeli's formula is applicable only to a 28-year-old, it's 28 regular menstrual cycles. Only in 28 regular, 28 days regular menstrual cycle only, just LMP plus 9 months plus 7 days is applicable. Now, Naegeli's rule can be used to calculate EDD only if a woman had regular menstrual cycles prior to conception and there is no history of oral contraceptive pill intake prior to conception. In case of the latter, ovulation may not resume immediately following the withdrawal of hormonal pills and there may be a delay of 2 to 3 weeks in resuming ovulation. So hence EDD may not be accurately determined with Naegeli's rule. So just remember, therefore Naegeli's rule is applicable only to a 28-day regular menstrual cycle. The formula is LMP plus 9 months plus 7 days. Simple formula. And if the woman had regular menstrual cycles prior to conception, and remember, it for women who's taking oral contraceptive pills, this formula is not applicable. So remember, for a woman who's taking oral contraceptive pills, this formula is not applicable. Now, but just remember, there will be 2 to 3 weeks delay. 2 to 3 weeks delay will be there for women who is taking OCPs. So, if at all, the period of ovulatory and fertilization age is typically 2 weeks less than the period of gestation calculated from LMP. It is mainly used for embryos. Okay, this is not needed. So now coming to corrected expected date of delivery. So what if the woman is not having a 28-day cycle? Then what will we do? So first, for cycle length greater than 28 days, we need to add up an extra 14 days to the EDD from Naegeli's formula. Simple. So for example, there is a woman who's having 35 days cycle. So 35 days means it's more than 28. So you need to add 14 days extra, right? So first apply the formula. What is the formula? The formula is EDD plus 9 months plus 7 days, right? So what we need to do is, we need to first subtract 35 days. See, 35 days minus 28 days is 7 days, right? So therefore the corrected formula will be EDD is equal to LMP plus 9 months plus 7 days. So for example, I'm giving you another example. So there is a for like 32 day cycle. Then what will we do? 32 minus 28, which is 4. So the formula will be LMP plus 9 months plus 4 days. So that's how it goes. So so you just need to remember that if for a cycle length greater than 28 days, you need to add 14 days extra. Now for cycle length less than 28 days, we need to deduct the number of days from the EDD calculated from Naegeli's formula. For example, there is a 25-day cycle. We need to deduct 3 days from this 28. So 25 days means 28 minus 25 is 3 days. So therefore you need to subtract 3 days. Simple. You just need to subtract the number of days. Now suppose if the cycle length is greater than 45 days or cycles are irregular, then what will we do? LMP is not reliable, and hence, see, for cycle length greater than 45 days or very irregular cycles, LMP should not be done because it's LMP is not reliable. It fails. LMP calculation fails. Hence, dating ultrasound must be done, and clinical examination findings are used for determining the period of gestation and EDD. So that time you go for dating scan. So only 4% of women will deliver on the EDD. So majority of women will deliver either 2 weeks before or 1 week after EDD. So now next let's look at some important Viva questions related to whatever we have covered so far. First question, what should be done if the patient does not remember her LMP? So a patient is coming to the OPD and you're asking the patient what is the last menstrual period, and the patient says, no, I don't know, I forgot. What will you do then? So if the LMP, the last menstrual period, is not known or the patient is not sure of LMP, the details may be collected from the following. First, you'll collect from a proper history. So women may be asked to relate her LMP to some important festivals or occasions that she might remember. For example, her last menstrual period was around Diwali time. So at least with that you can remember the clue, like which month at least was her, or which week, during which week was her LMP. So that's how you can relate her LMP to some any important festival or occasion. Next, ask when her urine pregnancy test kit when it was becoming first positive. So you need to ask when the UPT test became first positive. That is one. And the third thing you will ask is, you will ask for date of quickening. Date of quickening, that is quickening or perception of fetal movements for the first time during pregnancy is felt around 16 to 18 weeks in multigravida. So it is going to be 16 to 18 weeks in multigravida and 18 to 20 weeks in primigravida. So in multigravida it's going to be around 16 to 18 weeks, whereas in primigravida around 18 to 20 weeks. So quickening, so the fact is in case of multigravida, the quickening will be felt prior, much prior as compared to a primigravida women. Okay, so multigravida is more prior, is prior to the quickening felt in multigravida patients is going to be much prior to primigravida patients. Now details or dates of intrauterine insemination, in vitro fertilization, IVF, IUI are all known in women treated for infertility. Now let's move on to obstetric examination. So check the patient's antenatal records. Okay, if suppose the patient forgot the LMP, you can ask for the patient's antenatal record and you can check the uterine size in early gestation and for fundal height. And obstetric ultrasound, check whether the patient has done dating ultrasound in first trimester or any ultrasound in second trimester. Now, the first documentation of fetal heart rate by transabdominal scan is done at 7 weeks by a handheld Doppler at 10 weeks and by auscultation with stethoscope at 20 weeks. This is very, very important, guys. This is very, very important. So the questions they will ask is fetal heart rate by transabdominal scan, when it will be done, around 7 weeks. By handheld Doppler around 10 weeks and by auscultation with stethoscope 20 weeks. So fetal heart rate can be done by transabdominal scan, by transabdominal scan at 7th week and a handheld Doppler you will do it around 10 week and auscultation with stethoscope around 20 weeks. So 7, 10, 20 for fetal heart rate documentation. Now next, coming to the calculation, what is period of gestation and calculation? So period of gestation is very simple. You just need to add the total number of days from the first day of the LMP till date, and then you need to divide it by 7 to calculate period of gestation in weeks. And just after calculating, you need to check if the dates are good, excellent, or is it a bad date. So when you say that a period of when POG is going to be excellent, so excellent dates are women with adequate clinical information, that is known normal LMP, 28, it's a normal LMP and 28-day cycle, no recent use of OCPs, with uterine size in correlation with the gestational size, with uterine size in correlation with gestational size. So these 4 points are very important to say it's an excellent date. Okay, like a normal 28-day cycle LMP is noted, and with no recent use of OCPs, and the uterine size is correlated as same as the gestational size, gestational age, and with one ultrasound done between 16 and 24 weeks, of gestation correlating with POG as per LMP. So women with inadequate clinical information and with 2 ultrasound examinations between 16 and 24 weeks of gestation showing linear fetal growth and similar EDD. Now when do you say it's a good date? So women with adequate clinical examination, that is a known normal LMP, 28-day cycle, no recent use of OCPs, with uterine size in correlation with gestational age, and with one ultrasound done between 16 and 24 weeks, it comes under excellent date. So if at all one ultrasound is done after 24 weeks of gestation, then it is going to be a good date. So women with inadequate clinical examination and with 2 or more ultrasound examinations after 24 weeks of gestation showing linear growth and similar EDD. Now, so what do you mean by Naegeli's pelvis? What do you mean by Naegeli's obliquity, guys? So Naegeli's pelvis, it is a type of asymmetrically contracted pelvis due to arrested development of one ala of the sacrum. So delivery is by cesarean section mainly in case of a Naegeli's pelvis. So what is Naegeli's pelvis, guys? It's a type of a asymmetrically contracted pelvis, and where is going to be the problem? The problem is there is an arrested development of one ala of the sacrum, and therefore you will go for a C-section in this kind of patients. And what is Naegeli's obliquity? Naegeli's obliquity refers to anterior asynclitism. Anterior asynclitism is nothing but Naegeli's obliquity or anterior parietal bone presentation during vaginal delivery. So that is your Naegeli's obliquity. Anterior synclitism or anterior parietal bone presentation during vaginal delivery is known as Naegeli's obliquity. So these are some extra ages. So coming to what is antenatal care and booking. So this is very important, antenatal care and booking. So what is the definition of antenatal care? So define antenatal care. So what is the definition of antenatal care? Antenatal care refers to systemic supervision of a woman during pregnancy to monitor the progress of fetal growth and ascertain the well-being of the mother and the fetus. So you are going to monitor the fetal growth as well as the well-being of the mother and the fetus, and by doing a systemic supervision, and this is referred to as antenatal care. So what is the objective? The objective is to ensure a normal pregnancy with delivery of a healthy baby. So the main objective of antenatal care is what? To ensure a normal pregnancy with a delivery of a healthy baby from a healthy mother. So what are the aims of antenatal care? So the first aim is to screen for high risk cases. Next, to prevent, detect and treat any complications at the earliest. To prevent, detect and treat any complications at the earliest. Then to educate the mother about the physiology of pregnancy and labor, to alleviate any kind of fears regarding childbirth and to promote breastfeeding following delivery. To motivate the couple for family planning, very important, and to educate them regarding the available options. To give appropriate advice to couple seeking medical termination of pregnancy. So these are the aims of antenatal care. So what do you mean by antenatal care? So antenatal care refers to systemic supervision of women for mainly to monitor the progress of the fetal growth and to ascertain well-being of the mother and the fetus. So objective is to ensure normal pregnancy with a healthy baby. Aims are to screen for high risk and to prevent, detect any and treat any complications, to educate the mother about the physiology of pregnancy and labor in order to alleviate fears, and family planning, medical termination of pregnancy. So booking, what do you mean by booking? So, or when do you call a woman to be in a booked status? So booking refers to the number of visits made by the pregnant woman to the doctor. So number of visits. So ideally, what should be the number of visits? It should be 13. As per WHO, ideally the number of visits should be 13. In first trimester, 1 visit. In second trimester, once in every 4 weeks. In third trimester, around 28 to 36 weeks, once in 2 weeks, 36 weeks till term, and once 36 weeks till term, once in 1 week. So remember, booking is nothing but number of visits made by the pregnant women to the doctor. So the ideal number of visits is going to be around 13. So first trimester, the women should, during first trimester is 1 visit. Second trimester, so if you see second trimester, once in every 4 weeks. Third trimester, if at all the mother is during 28 to 36 weeks, then during that duration, once in 2 weeks. And if at all, if the mother is if the woman is from 36 weeks till term, then you will do once in 1 week. Okay, once in a week the women should visit. So ideally 13 number. So now WHO recommendation for booked pregnancy. When you say a pregnancy is a booked pregnancy, a pregnant woman is said to be booked if she has had a minimum of three antenatal visits after her pregnancy was registered, out of which 2 visits should be in the third trimester. So now currently they have changed just booked pregnancy into 4 antenatal visits, and out of which 2 must be in the third trimester. So 1 in the first trimester, 1 in the first trimester, 1 in the second trimester, 2 visits in the third trimester. So totally 4. This if there are totally these 4 visits, then you will term the pregnancy as booked pregnancy. Now she has been provided with iron and calcium supplementation and also 2 doses of tetanus toxide. These 2 doses of tetanus toxide are given okay, so this 2 weeks, right? This 2 weeks of tetanus toxoid vaccine, right? So this should be given 0.5 ml intramuscularly 4 weeks apart. Very important Viva question. 0.5 ml intramuscularly 4 weeks apart. Now, it should be emphasized that these 4 visits following the registration of pregnancy are a minimum requirement, and more visits may be required. Okay, so the timing: first visit, as I told, should be within 12 weeks. Second visit should be during the second trimester. Third visit between 28 to 34 weeks. Between 28 to 34 weeks. Fourth visit between 36 weeks to term. So 36 weeks to term, one visit, and 28 to 34 weeks, one visit. So now let's see the proforma for history taking and examination as a brief. So first you need to take down all the details of the patient profile, like she is Mrs. of dash, years of age, wife of Mr., resides at which place, educated up to what, and works as a dash. So she belongs to which socio-economic status according to modified BG Prasad scale. Her nearest health center is from which place, and how much time does it take to reach from the nearest to the nearest health center. Then you need to write about her obstetric score. Gravida, para, live birth, abortion. So, and say GPLA. So her last menstrual period was on when? And for last menstrual period, you should not just ask only the date, but along with that you need to ask if the menstrual cycles were regular or 28-day cycle, and whether OCPs were taken prior to the conception. All this must be asked. Now her expected date of delivery will be calculated, and POG also will be calculated based on the formulas. So mention whether she is booked. When do you say booked? For minimum antenatal visits and immunized. Generally students will forget to tell if they will just tell she is a booked status. It's a booked pregnancy, but no, you need to mention whether she is booked and also immunized. You should mention it like she you need to she's a booked case, and immunized. Immunized means you're telling the TD doses. If the 2 TD doses are taken 2 weeks apart, then you will say the status as immunized. And then very, very important obstetric history: blood group. Blood group should never be forgotten. Blood group is asked mainly for whether to know if it is a Rh negative pregnancy or not. And students, just don't forget, for studying and for for memorizing everything, you can use the short forms, but generally use the expanded forms during your examinations. When you are presenting your paper in examination, write all the full forms. Now coming to the presenting complaints. So presenting complaints, the various presenting complaints of the patient should be always in chronological order. That is the first complaint, then to the last complaint in chronological order, that is from the time of onset, which complaint was first. Now common presenting complaints during antenatal period are the following: excessive vomiting, swelling of feet, bleeding per vagina, leaking per vagina, pain abdomen, decreased fetal movements, breathlessness, white discharge per vagina, burning micturition, All of these are very very common complaints. Okay, so once again I am go through excess vomiting, swelling of feet, bleeding per vaginum, leaking per vaginum, pain abdomen, decreased fetal movements, breathlessness, white discharge per vaginum, burning micturition, all of this. So if no complaints are there, you need to mention that the patient has come for routine antenatal checkup and admitted for safe confinement. This is the way you need to write in your case sheet. So in your case sheet, if no complaints are there, what should you write? In the summary, especially in the summary and all, you need to mention that the patient has come for a routine antenatal checkup and admitted for safe confinement. Now next, coming to the history of presenting complaints. So you need to elaborate and describe the presenting complaints with details such as mode of onset, severity, duration, aggravating and relieving. That is OD par, guys. OD par. All medical students should know this. O for onset, duration, progression, and aggravating and relieving factors. So history of present pregnancy, first trimester, what all you'll ask, whether it is a spontaneous conception or a following infertility treatment. First question what you need to ask is whether it was a spontaneous conception or whether it was following an infertility treatment. So the pregnancy was confirmed at, so this is how it goes, the pregnancy was confirmed at dash days of amenorrhea, how many days of amenorrhea, and detected by what? Was it detected by urine pregnancy test or ultrasonography? Okay, and at which place? Which place should be mentioned? History of hyperemesis gravidarum, that is severe vomiting, should be asked. History of fever with rashes. History of bleeding per vaginum. History of exposure to radiation. History of drug intake. Whether antenatal investigations as well as dating scan have been done and said to be normal. All of this. Okay. Now, along with this, you should also ask whether folic acid supplements or any other are started to be taken or not. Second trimester, number of antenatal visits is very important, and time when quickening was felt, the time that when quickening was felt, history of tetanus toxoid immunization, the number of doses and period of gestation at which the injections were received, history of iron and calcium supplementation, history of bleeding per vaginum, history of symptoms suggestive of preeclampsia such as excessive weight gain, swelling of feet, decreased urine output, headache, blurring of vision, epigastric pain. So very very important, and during case viva they will ask you just what are the symptoms suggestive of preeclampsia. Very very important. What are the symptoms suggestive of preeclampsia? Excessive weight gain, swelling of feet, decreased urine output, headache, blurring of vision and epigastric pain. So whether the screening test for gestational diabetes mellitus was performed, it can be either OG, CT test, oral glucose tolerance test, or oral glucose challenge test, or OG, TT, oral glucose tolerance test, anything. So whether fetal anomaly scan was done and said to be normal should be asked. So during the remember guys, generally dating scan is done during the first trimester, and NT scan is done during the second trimester, and growth anomaly scan is done during the third trimester. So again ask for the number of antenatal visits, histories of preeclampsia suggestive of excessive weight gain, swelling of feet, decreased urine output, headache, blurring of vision, epigastric pain, whether perceiving normal fetal movements or not, history of iron and calcium supplementation, very important. So 60 milligram elemental oral iron. What is the dosage of folic acid? Ideally ideally 400 microgram, but it can also be given as 500 microgram. So all these doses should be paka, and you need to know all the doses. So next is history of bleeding PV, leaking PV, pain in abdomen, bowel and bladder disturbances, all should be asked. Now coming to the menstrual history, what is the age at menarche? When was the age at menarche? Menstrual cycles, whether it was regular or irregular cycles once in how many days? Like for example, cycles once in 5 days, once in 28 days, lasting for around 3 days. This is how it goes. 28 days lasting for around 3 days. Whether the flow is moderate or profuse or scanty, history of associated clots or dysmenorrhea, and LMP. Now always end the menstrual. Remember, some very important point to be noted. Always end the menstrual history with LMP. The last menstrual period. Always end the menstrual history with LMP. Coming to the marital history. Marital history, married for past how many years? Whether it was a consanguineous marriage or non-consanguineous marriage. If it is consanguineous, you need to mention the degree of consanguinity, whether first degree, second degree, or third degree. Yeah, so first degree means whether with parent or a child, and second degree means with either grandparent or brother or sister or grandchild. Third degree consanguinity is great grandparent or uncle or aunt, niece or nephew or great grandchild, like that. Now past obstetric history. So pregnancy was confirmed at dash days of amenorrhea must be done. Again UPT UST, how many days of amenorrhea, whether she was a booked case and whether she was immunized, whether the antenatal period was uneventful or had any complications such as preeclampsia, gestational diabetes mellitus or antepartum hemorrhage, name of the institute where the patient delivered, admission details like period of gestation at which the patient was admitted, whether admitted with labor pains or leaking PV, like that. So onset of labor, whether the labor was spontaneous or induced labor, is very important. This you need to ask. Whether it was a term, preterm or postnatal delivery. So whether spontaneous vaginal delivery or instrumental delivery or cesarean section. So if cesarean section was done, detailed history to be taken as mentioned in a case of previous lower segment C-section. Okay, so and last, history of blood transfusion. So these are all the details you will collect from the mother, and next you will collect also baby details, whether live or stillbirth, if at all stillbirth, whether fresh or macerated, cause of death if known, then sex of the baby, the birth weight, whether cried immediately after, this is important, whether the baby cried immediately after birth or any neonatal intensive care unit admission, any congenital anomaly was done. So time of starting breastfeeding, the baby breastfed the baby for how dash hours after birth. So how many hours? What was the time of starting of breastfeeding of the baby? Present age of the child and whether healthy. Next, coming to puerperium. Puerperium, I already told, it is the period from the delivery till up till 6 weeks after delivery. So mention whether uneventful or whether had complications such as fever, foul smelling, lochia, wound gapping, history of prolonged hospital stay for any specific reason. Then contraception details like history of contraceptive usage in between pregnancies, method of contraception used and for how long. In case of past history of abortion, if at all any past history of abortion, you need to ask confirmed pregnancy by UPT and how many days of amenorrhea, spontaneous or induced abortion. If at all if it was an induced abortion, what was the reason for induced abortion, period of gestation at which she aborted, and whether medical or surgical abortion is important. So any fever, foul smelling discharge following abortion, and time when the patient resumed the menstrual cycles following abortions, and history of any contraception following abortion. Now next, coming to past history. So medical history, any comorbidities like DM, hypertension, TB, jaundice, epilepsy, bronchial asthma, thyroid disorder. Surgical history, any past history of any surgery, history of blood transfusion, history of sexually transmitted diseases. Personal history, sleep, appetite, history of any addiction such as tobacco use, alcohol, smoking, history of drug allergies or drug intake for chronic illness. Then coming to dietary history, whether mixed or vegetarian diet, a record of the patient's patient's daily food intake should be documented to calculate the daily calorie and protein intake. It is mentioned as calorie intake in dash kilocalorie per day and protein intake in dash gram per day. It is mentioned whether diet is adequate in calories and protein intake, or else mention that the diet is how many percentage deficient in calories and how many percentage deficient in protein intake. Now coming to the family history, ask for diabetes mellitus and hypertension if it runs in the family or not, TB in the family, multiple pregnancies, multiple pregnancy, congenital anomalies and genetic disorders. So yeah, TB, multiple pregnancy, congenital anomalies and genetic disorders. Now moving on to the summary of history. So a summary is made at the end of the history taking, okay, and should include the patient's name, the age, the obstetric index, the LMP, the EDD, the POG, the chief complaints, significant positive and negative history, and any associated complications. Now pregnancy can be identified as either a low risk pregnancy or a high risk pregnancy. And you need to complete the history taking. So this is all about the entire history taking of an obstetric case, okay. So next we'll be moving on to clinical examination. So yeah, we have covered all the like the basic definitions, like what is gravida, what is para, what is live birth, what is abortion, what is EDD, how to calculate, what is Naegeli's rule, okay, and what is antenatal care, when do you say it's a book status, and a pro forma of history taking is all covered in this video. So, and the summary of history. So in the next video we will be continuing about the rest of the part will be continuing in the next video about the clinical examination findings. All this will be covered in the next video. So yeah, to stay tuned and continued, please do subscribe and like this video. Thank you.